Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Millicent Rovelo, and I'm here with, I think, my finally now adequately caffeinated co-host, Dr. Jay Calvert. How are you?
I am definitely caffeinated. Ready to go.
Great. We chugged our coffees and we came in here and we're ready to go.
I know, and I like this topic a lot.
Yes. Today's topic is Tummy Tuck 101. We have done Tummy Tuck 101s before, but it's been several years. So it's time to update them with some new ideas, tips, and tricks. But the idea is that because this is a 101, we're going to keep it very general, sort of like what you need to know before, during, and after your tummy tuck. In a nutshell, we have multitudes of other podcasts that do deep dives into certain aspects of a tummy tuck, but this is just the overall what you need to know. Welcome to Tummy Tuck 101.
Yeah, and I think it's important because people think, and the technical term for the procedure is abdominoplasty, and a lot of things get mixed in with abdominoplasties, with everything from doing high-def liposuction, doing circumferential body lifts with your abdominoplasty, to doing, how to, maximize the contouring of the abdominal wall. So we'll get into all that. But yeah. I just want to mention that your abdominoplasties look great. I've been checking them out online. They look
thank you
really
very much,
awesome.
Doctor.
And, I'm not sure why anybody's going anywhere else for them, but that's just just me.
We live in a democracy. People can choose what they want to do. I know.
Like if I needed one, which I probably do, then I'll get on the table and we'll take care of that. So.
Well, thank you, doctor.
So let's walk through it. Say you're the patient who's thinking about this thing hanging off my belly needs to come off. When is the tummy tuck the right operation?
So who needs a tummy tuck? A tummy tuck, by definition.
No, just kidding.
A tummy tuck, by definition, is really designed for anybody who has extra skin, really, of the abdomen. And there are lots of other things that go into what makes a tummy tuck. But at its core, get that core, it's designed for women and men that have extra skin of their abdominal wall. And this could be from weight loss, or it can be from having babies. And it can also be from just general age over time.
Yep.
You can have a woman that's never had children before, never had any weight loss issues, but as she gets older, 50s, 60s, just notice that the skin of her abdomen is a little bit looser and not as tight as it was. So the main thing is anybody who looks like they have extra skin. Now, usually...
What about the abdominal wall muscles, though? Because that's a big part of a tummy tuck, so...
I'm getting there.
Oh, okay.
You're ready to go.
I'm ready. Your question should then be, are you going somewhere? I'll be right here. Go ahead.
But typically, it's not just extra skin. There is frequently in women who have had babies or in anybody that's been overweight for a long period of time, some weakness or laxity is the doctor word of the abdominal wall muscles. And this usually refers to the rectus abdominis muscles. Those are the six-pack muscles, the ones that run up and down your abdominal wall and give you the six-pack. You can have those muscles separate. They're supposed to sort of touch each other in the midline, but with age and babies and weight gain, weight loss, they can separate. And when that happens, they don't actually function as a muscle. They don't work well because they're not in proper anatomic alignment. And so what happens is the abdominal wall contents can kind of push themselves out. I don't have women that come in and look like they're still 9 months pregnant because they just have no abdominal wall tone and they need to have those muscles repaired. So that is another component of the traditional tummy tuck. It's the skin excision and then it's repair of those muscles. The idea being to tighten and flatten the abdominal wall. Although, that being said, the third component that almost just about everybody gets is liposuction. So if you are coming in with extra areas of fat that you don't like, that are of excess, then those are also traditionally addressed with the tummy tuck. And it can be a little bit of liposuction for someone who just has a little bit of extra fat, maybe on the sides that they don't like, or it can be a whole separate procedure, 2-3 hours of liposuction, getting the whole trunk, the back, the sides, the waist, the upper abdomen, before we even start doing all of the tummy tuck procedures. So there is variation, usually with how much liposuction is done in any given patient. So then you present, you say, this is what I'm thinking about, and you come up with a plan with your doctor that addresses all of those things and to what degree you need all of those repaired. And
they're all customized.
It's all very customized because everybody comes differently and they all have different things.
That's right.
I have some little moms that comment are literally just skin and a little bit of muscle separation, and they don't need as much. Then you have someone that comes and needs a lot of liposuction. So it's all incredibly customized.
Good.
But whatever sort of option of surgeries you end up choosing, you're going to start talking about the actual surgery and what you can expect. So the surgery itself is something you come the day of. It can take anywhere from 3 to 6 hours, depending on how much work needs to be done. My preference is to send patients to an aftercare facility, or if I'm doing it in a hospital setting, I have them stay overnight in the hospital, just so there's somebody who for one night is watching you and taking care of you after the surgery.
I think that's smart, and I also think that there is, with abdominal and pelvic surgery, higher complication rates. There really are. And so, getting clots in the legs and the pelvis and things that can happen with these operations are, although they're rare, it's not zero, and abdominoplasties are an operation you want somebody paying attention to your respiratory status, how, getting you up out of bed and, walking hunched over, all the things that need assistance. And typically the husband isn't the best nurse for that purpose. Sometimes the husband is a nurse, and that's great, but like doctors, not good aftercare.
Not great nurses.
If it's the wife of a doctor, or just go with the aftercare, please.
Yeah,
we learned that lesson over and over. Doctors are not nurses.
We're not the most caring in terms of how we take care of patients
we're just not nurses.
We're not nurses.
We care very much.
Yes, we do.
I just don't know how to be a nurse. I'm terrible at it.
So, yes. So you'll probably, if you're having it with me or someone, in the Beverly Hills area, go to an aftercare facility. But what you can expect. So the surgery itself, like we talked about, let's talk about these incisions. So the length of the incision is something people always ask about. And the length of the incision is not really up to me. It's up to what you come to me with. And if you are very itty bitty and all you have is a little bit of extra skin, you'll probably have an incision that sits right in the lower abdomen and goes sort of hip to hip, right up to the hip bones, like a little smile. It's hidden in the bikini area. It's hidden under the underwear. I put my incisions typically fairly low, but kind of curved to have a nice, pretty feminine curve to the incision. If you have a lot of extra skin or a lot of extra fat, that incision's going to be longer. I'm sorry, there's no way around it. It will go up and over, kind of and around the hip bones, out towards the side some more. And if you don't do that, you're going to have what's called dog ears. And that's where the extra skin that's you didn't take out because you didn't want to extend the incision is still there. And the front part is nice and flat. And then you have these little hangy offy things, the sides of your incisions.
Why are they called dog ears? I just am like, why did we name them dog ears?
Dog ears, little doggies. They just hang off the side. And
the little pooches of skin that just aren't cute.
And so to avoid that, you have to make a longer incision.
Yep.
And I was doing a case with a friend of mine once, and she and I were both working on a dog ear. I think we were working on the breasts, maybe. And she said, I don't think patients really understand how hard we work to avoid dog ears.
It's true.
Our incisions and our surgeries, we spend so many extra minutes trying to tuck the skin on the side so that we don't have to make the incision longer. And we really do everything we can to minimize how long the incisions have to be. And that includes doing some fancy footwork at the ends of the incisions because we are trying to minimize the dog ears. But the length of the incision is really determined by what you come with and how much extra skin and tissue there is.
Yeah,
but the incisions heal, and they usually heal really well.
They do. And the dog ears, just so that people understand why that happens, it's because you're taking a curved incision. It's at the end of the incision. And when you bring it together, it kind of tense up. Mm-hmm. So to get it to flatten out, you have to make it longer.
You have to cut it out.
That's just the way it is.
It's just, I don't know, it's physics, it's geometry, it's what it is.
And it's part of what we have to deal with to make it look nice.
But that's the incision, and then we elevate the skin and the fat off of the abdominal wall, and we elevate all the way up to the xiphoid, which is the breastbone or the sternum. So imagine going from your pubic bone, releasing the skin all the way up to the top of your ribs. Now this is where you were asking about the liposuction. If I've done A lot of liposuction of the upper part of the abdomen, I keep that elevation fairly narrow. And the reason for this is because you have to have blood supply to the skin that's remaining. And if you do a ton of liposuction all over the abdomen and then you release the skin all the way over the ribs and up towards the breasts, you're not going to have any blood supply left. So that's where kind of experience and knowledge of what you're doing comes into play, knowing how much liposuction to do, how much skin to elevate. These are all really important factors in making sure we don't have complications after.
Yeah, I mean, that is the, I remember taking an abdominoplasty course when I was a resident with Alan Matarazzo. And back then they said, boy, if you do any central suction, you really need to be careful. And they recommended just doing lateral suction only with the abdominoplasty and kind of living to fight another day and coming back if you had to contour, if they really needed to be thinning of the abdominoplasty flap to suction it later. Coupled with that, I've sort of learned that you can do some suction with it. I prefer to do open defatting. And then keeping that elevation pretty narrow is the key to keeping the blood supply intact as you tuck the tummy, as you pull down that flap and bring the belly button through.
I'm very liberal with my liposuction, sort of a lot of times out of necessity, because I can't have a big thick flap that I'm bringing down. Like I need to thin it and defat it and make sure it's thin enough. Otherwise, I'll have other complications related to wound healing. So I'm pretty aggressive with how much fat I take out of the whole abdomen, but on the back end, I just make sure I don't dissect too much and take away too much extra blood supply. So the skin is lifted, it's elevated, which allows us to pull it and move it and redrape it. Once it's elevated, we're looking right at the abdominal wall muscles. This is where we can see exactly how separated they are, and we can do our suture repairs. And there's all kinds of sutures, all kinds of flavors, and it's really surgeon dependent, and we don't need to get into the weeds on it. I personally like a permanent suture. I use a Prolene suture, and I do 2 layers. The second layer is an absorbable suture. That's not that important. Everybody does it differently. As long as you like the results and as long as they stay and stick around, that's all that matters.
That is true. Putting the muscles back together is key. And I think that is a technical point that is sort of overlooked by a lot, but I tend to put the muscles back together in a way that it's almost an overcorrection, because if you just put them together the way they are, well, the whole abdominal wall is still lax, and you're just going to get a poochy abdomen. So you kind of have to tighten things down, and even I do a lot of lateral suturing too. I don't know if you do that with your tummy tucks.
Here and there.
Here and there.
Here and there. Yeah.
That's true.
Because the problem I have is that a lot of times, yes, if you just bring the muscles together in the midline, you can repair technically the diastasis. But if you've been overweight for a long time, or if you had a really large baby or a twin gestation, the abdominal wall muscles themselves are just not great quality. Like if you think about a rubber band that's been overstretched and then you just try and put it back into its smaller size, it'll never snap back. Like they've kind of lost their snapback ability. So it's not, it's uncommon, but sometimes I will have patients that even though I've tightened them up as much as I can, their abdomen still pooches out a little bit. And usually that's because the abdominal wall muscles are just not great quality. Maybe doing some core work might help. Or the other thing that no one wants to hear, they still have intra-abdominal fat that is pushing their abdominal wall out. We can do a lot of work on everything outside of the abdominal wall, so from the muscles to the skin. But if you have a lot of internal fat wrapped around your organs that's causing your abdomen to stick out, there's nothing that I can do about that. That's just good old-fashioned weight loss. So there are some limits to how flat and tight we can get the abdomen, but usually we can get it pretty flat, pretty tight, and certainly significantly better than how we started.
Yeah, and well, let's talk a little bit too about we manage the belly button, the umbilicus.
Yeah, so once we've done all of the work, we've done the liposuction and the skin and the muscles, now it comes time to addressing the extra skin. So we've elevated everything. I sit the patient up into what we call a beach chair position. So we bring the back up pretty high, we flex the hips. So like imagine, you're sitting at the beach. And that allows us to take out a lot more skin because we can get the top and the bottom parts of the incision really close together. I estimate how much skin I can take out. And my goal is always to take out up to above the belly button. Because the belly button, let's talk about the belly button for a second. The belly button is a very tethered part of the abdominal wall. When we do a tummy tuck, classically, we cut all the way around it and release the skin from all the way around the belly button. If you don't do that, then the skin that's above the belly button will never move down. No matter how hard you pull it, it will never reach your incision. So you have to release it. And so now you have this extra skin, and it includes that old belly button hole, which is now just sort of this hole in the middle of the skin.
Yep. It's just sitting there looking at you,
going like, looking at you, what are you going to do with me?
That's right.
And so ideally, you would be able to get that old hole where the belly button used to be out with the specimen that you remove, the entire skin flap. But if there's not a lot of extra skin, sometimes you can't. And so if that happens, you pull really tight as hard as you can, and you realize that old hole is just sitting, a centimeter or so above your incision. Nothing left to do but just close it. You close it up as a little vertical incision. It usually sits right above your horizontal incision. And live to fight another day. You can always come back and excise it down the road as things stretch out again. But theoretically, you can get the whole skin out, including that old belly button hole. And now you're just left with a flat abdomen, and you need some place for that belly button, which is now just floating attached to the abdominal wall, to come out through the skin.
Yeah, so you gotta make yourself and everybody does this differently.
Totally.
I have seen I've seen belly buttons that look amazing afterwards. They look very natural, normal. I've seen ones that look like sunburst scars that look terrible. I've seen ones that look like tortellinis that are just awful. So it just depends on how the surgeon does their belly buttons, because it is a really key point.
Yeah, this is like the worst part of the case for me, because it's like very stressful, because I will do this like beautiful abdominoplasty, and now I have to like close it, and it's like the icing on the cake is getting that belly button right, because it gets screwed up. It's like, ugh. It's like the one thing everybody looks at.
That's right. They do.
They do. It has to be great. So I've gone through a couple different iterations of what I like, and I keep coming back to what I call the inverted V incision. It's a little upside down V made in the skin once we've gotten everything closed. And then I go in and I say a little prayer and hope that my belly button is right where I think it's supposed to be. And I pull it out and I suture it to that inverted V incision that I've made. And this is where I learned very early on, sutures matter. So this is not a place to do sutures that go through the skin, because that's where you're going to get that starburst thing that you show. This area does not like stitches. It can scar pretty poorly. So I do really fine sutures internally in the skin of the belly button and all the way around it to really tuck it in there and get it seated nice and pretty, but without an external suture that's going to leave a scar.
You nailed it. I mean, a belly button is a scar. This is the scar of
where you're attached to your mama.
Yeah, I mean, that's what it was. It's where your umbilical cord attached to you. So it is a scar, and it doesn't heal great. So how you manage it is really key to the aesthetics of the aesthetic result of your abdominoplasty.
Yeah, that's a very, and I think almost like a surgeon calling card is like how their belly buttons look, because it all looks a little different, and they look a little funky in the beginning. But I saw a patient, I don't know, a while ago, and she came in for like her breasts, and I had forgotten that I'd also done her tummy tuck, and I was examining her abdomen, and she had this like beautiful tummy, like little umbilicus, and I was like, "Who did your tummy tuck?" And she was like, "You did," and I was like, "Oh, it looks fantastic." Like over time they heal really well. In a couple of years, like they look very natural.
You gave yourself an attaboy.
I did. I was like, I did? Oh, it looks great.
Pretty good. Take some photos for the website.
So that's the belly button. And then what I like to do, patient dependent, is do these progressive tension or quilting sutures at the time of closure. And these are sutures that go from the kind of midline of the abdomen, from the sternum all the way down to the pubis, and then a few out on the sides as well. And they really help to contour the abdomen and give it sort of that toned, defined shape. But these are absorbable sutures that go underneath the skin and then tack it down to the abdominal wall as you're closing. And they do a couple things. They really help the skin lie flat and give you some definition, but they also minimize the dead space, which is space where fluid can accumulate. So theoretically, some people will do just progressive tension sutures and not leave a drain at all. I'm not a fan of that for my own reasons. I like the comfort of having a drain because there is going to be fluid, especially if you've done a lot of liposuction.
Right. 100%.
And I just like the safety of having a drain there. So I'll typically do progressive tension sutures and a drain. The only group of patients I do not do progressive tension sutures in are my massive weight loss patients. My massive weight loss patients have really loose skin. And even if I remove all the extra skin, the skin that's left behind is not great quality. It's really loosey-goosey. And if I do these tacking sutures down the center of the abdomen, they keep what looks like a front butt. Like their skin kind of folds in on itself around these sutures. Well, that's what they tell me.
That is not cool.
So I also learned that early on, real quick. These are not the patients to put these quilting,
Yeah,
and they don't need it because their skin's pretty stretchy. They're going to get a drain no matter what. So
Drain or two.
Those patients typically get two.
I don't think I've done an abdominoplasty on a massive weight loss patient when progressive tension sutures are in vogue. So now I will definitely avoid the front butt.
You don't want the front butt.
Should I do? But yeah. I don't get those patients. Those are your people.
Yeah. But everyone else gets those sutures. And then, like we said, the drains. We have a whole podcast about drains. Don't fear the drain if that's
right.
what your surgeon chooses to do. They will be there for a short period of time, and then they'll be out. And if you've avoided having complications like a seroma or fluid collections, great. You're welcome.
Yeah, and there you go. Those progressive tension sutures are key, though, in like the abdominoplasties for the moms and the mommy makeovers and all that.
And they look great. They do, but they are absorbable sutures. So in the beginning, sometimes they can look a little strange. Like you'll have these like really severe indentations
there could be dents
where the
and
suture
dimples,
is, and the people kind of go, "Oh my gosh." Give it 3 weeks. Once that suture absorbs, you won't see that dent, and everyone will forget it was even there. So we've finished the surgery. I put my patients in a binder right away. Some patients will put them in a garment. They'll bring their own post-op garment. For me, while there's swelling and drainage and drains, it's easier to just put them in a binder you wrap around your waist and send them off to the aftercare facilities or wherever they're going. Post-op instructions. For that first week, and there's a post-op abdominoplasty podcast, just so you know. But
there is.
In general, for that first week, you're going to be sitting in that beach chair position that we put you in when we closed you. So you can use a recliner. You can just prop pillows on your bed or your couch. You don't have to get super fancy. But the idea is that you keep yourself kind of crunched to protect that incision and keep it from stretching out too soon. For the same reason, I ask that you walk bent over at the waist. For that first week, a walker with wheels is very helpful during this time period. But then after a week, you can stand up straight and you can start sleeping however you want. As those drains come out, I typically transition patients over to a faja or some other commercial compression garment designed after surgery. And I have them wear it for at least 6 weeks, but ideally up to 3 months.
Yeah, I mean, the garments I think are important, but I also have seen problems with garments, so I like them to get out of the garments a fair amount. I usually tell them, like, I think you should be in this garment for 16 hours out of the 24 hours in a day. Take some time to be out, take a shower, whatever, just so that there's, like, some relief of the pressure points, because some of the garments they're not one size fits all, and though the garment companies would like you to believe that they're so customized it's not an issue. It's not. So you do have to kind of be careful. And as I tell my patients, if you see something that doesn't look right, please call me.
Yeah. I actually had a patient just yesterday in the office tell me, I was put in this faja that the lymphatic person told me about. She's like, and it did not feel right. She's like, I knew it was supposed to be tight, but I looked at it, feel like my skin was turning blue. She's like, so I took it off. I was like, thank you. Thank you for having that common sense. So yes, they should be tight, but they shouldn't be cutting off your circulation. So if it really doesn't feel right, then it's probably not. But I agree. I tell them, wear it for most of the day. I like a day and night. But if you're at home and you're just sitting and watching television and you want to loosen the snaps and let the skin breathe a little bit, that's fine. The other thing, as I just alluded to, are lymphatic massages. So these are specialized massage therapists. And I say go to them as soon as you can, but ideally within a week or so after surgery. And they do a really good job at massaging these surgical areas and getting out the fluid, getting out the swelling, and making sure that the result is very smooth. Because you can have some issues in the healing period where scar forms, little areas of fibrosis, and the areas of liposuction. And the massages are really good at making sure that those don't stick around and smooth out over time.
For sure. And I do think that there's a lot of benefit to lymphatic massage and in sort of the post-surgical kind of moving the, we put in all that tumescent fluid,
Right.
and there's a little bit of blood here and there, that's like all that can move along and create better healing. So I do like lymphatic
Yes.
massage a fair amount.
Yeah, I'm a big fan of that. And so then I just say, take it super easy for a couple weeks. If you have a desk job, you can go back as soon as the drains are out. So you're looking at 3 weeks, maybe something like that. If you can work remotely, even better. But for my teachers, my nurses, anybody that has a really kind of more physically demanding job, I ask that they take at least 4 to 6 weeks off. 6 weeks, especially if they have to do actual heavy lifting. There's no heavy lifting, nothing strenuous for 6 weeks. After 6 weeks, you can get back into light exercise, start light, work back to where you were. I say closer to the 8-week mark before doing dedicated core abdominal work. But then after 6 to 8 weeks, you're off and running, you're on your own, you can do as you please. But the results will continue to get better. I love patients when they hit the 3-month mark.
Yep.
That's when things really start to come together. 6 months is a little bit tricky because I find patients have started to gain weight sometimes once they get to the 6-month mark. Because they're like, oh, I have this new body and I got the liposuction and I can have that extra cupcake now.
The wine is better.
Yeah. So just, you have to maintain these results. You really, just because you got skinny in a new body doesn't mean you don't have to keep working to maintain it.
It's very true. They do... they'll come back.
3 months is the window for the photos.
That's the time to get it because, like 9 months, they're like, I don't understand what's going on here. Like, this looks a little bit bigger to me. I'm like, it does.
Let's go back to the photos, the 3-month photos.
Yeah, because that's what happens,
It happens.
It does. The
It definitely
dietary
does.
issue is very real, and there's a metabolism issue, and there's a lot to this. So, like, again, that's where you really have to develop your health and aesthetic attitude, which is about getting the stuff lined up for yourself. If you really want to make big strides in it, you have to. It's a comprehensive approach. It's not just the surgery. There's the dietary issues. There's the hormonal issues. There's the the health issues, taking care of your heart. All that. All those things are very much part of having great results in aesthetics.
Yeah, and people always ask, well, how much weight do I need to lose before surgery? My answer is, I want you to be at a stable, healthy weight that you can maintain afterwards. I don't want you going on a crash diet and then gaining 10 or 20 pounds after surgery.
Totally.
So get to a weight that makes sense for your body that you can maintain postoperatively. And that is the weight that you should be before surgery. Briefly, let's just go through the complications. We always do that real quick just so we can make sure that people understand. These are very real surgeries. They can be big surgeries depending on how much liposuction and skin is being removed. So they are not to be taken lightly. Of all the surgeries we have, this one has the highest rate of blood clots. So these are blood clots in your legs that can travel to your lungs.
Yep.
Those are called DVTs that become
Pulmonary
PEs,
emboli,
pulmonary emboli. Very rare, but they definitely happen. I've definitely seen one. Most of my colleagues have seen 1 or 2 after these surgeries. And the reason for that is because we've pulled your abdominal wall really tight. We've put you in these crunched post-op positions, and it impedes the blood flow, the circulation coming from your legs back to your heart. And so the blood can stick and kind of clot and not flow as well. And so when that happens, you can get a clot in your leg, which then goes to your lungs. For most of my patients, getting them up and walking them that first night and that first week is sufficient to prohibit that from happening. But in anybody that has any kind of higher risk factors, whether it's personal or family history of blood clots, if they have a history of recently being on oral birth control or anything like that that elevates their risk, I do put them on prophylactic Lovenox, which is a blood thinner they start taking the day after surgery.
It is the very real complication of abdominoplasty. The others that come up are infections in the fat, that can take time to go away. They're not skin infections. When you get what's called a paniculitis, the fat gets infected. It can take a long time to get that.
Thank goodness that's very rare.
It is. It's rare.
Yeah.
Fat necrosis, getting little areas of painful scarring in the fat because you took a lot away. That does happen too. Seromas, having to
Fluid
drain,
collections.
despite the fact that we sew down the flap with our progressive tension sutures and use a drain or two, and you can still get a seroma that you got to go fish out of there with. With seroma is just a fluid collection of serum, of your body fluid. It's typically straw-colored yellow, clear, and you just take it out with a needle and in varying
Sometimes
degrees.
a couple times.
Yeah, it can take a few times to get it out, and if it gets organized, then you get what's called a seroma cavity that you have to go in and literally cut it out.
Yeah,
so
surgically.
that's also pretty rare, but
It happens.
I've had to do it.
Yeah.
I'm not going to sit here and say it doesn't happen. I've done enough tummy tucks that those things have all happened to me.
Definitely happen. Wound healing issues, those are not uncommon. But all of the other, short of the pulmonary emboli or that stroma capsule you mentioned, most of these are issues that can be addressed in the office with some wound healing, some local wound care. I put patients on a scar regimen 3 weeks after surgery, and I tell them when they're ready, and then we talk about scar creams and different options. There's lasers, there's microneedling, there's all kinds of things you can do for the scars. The main thing to know in the post-op period is to go to your follow-up, because that is where your surgeons will really be able to pinpoint maybe issues you didn't see or you didn't know you have, and the sooner we can address any potential problems, the better they are to heal. And just that constant communication with the doctor of like, okay, you're at week 2. This is what you can do now. And now this is what you can do is really what's going to make sure that you heal and have the fewest amount of complications possible.
Agreed. It's a big operation. You need the follow-up. It's not a one and done and just go out about your merry way. You need to have the follow-up and have your doctor involved in that.
Correct. And lastly, doctor, cost.
$1 million. No, I think it's I think tummy tuck for me, like right now, is probably around $45,000-$50,000. In Beverly Hills and at my level, I think most people maybe charge $35,000 or something like that. In other parts of the country, it's probably 25,000. But again, we have to preface it with it's February of 2025, and you don't know where the pricing will go from here. It's going to obviously get more expensive, but it's variable. And it depends whether you're doing it with other, like if I do a mommy makeover where I'm doing like some sort of breast lift, implants, and a tummy tuck, $70,000, $75,000. I mean, it's a lot of work. It's a 6-hour operation, lots of post-op care, et cetera. That's probably Beverly Hills prices. I think around the country, maybe 45 for that kind of thing.
Yeah, I think
I don't know.
those are very much Beverly Hills prices. And the cost is going to depend greatly on how much work is done. If we're spending 3 extra hours doing liposuction, well, that's a whole liposuction case.
Yeah.
In addition to the tummy tuck.
To the tummy tuck, and that's
so
gonna be
those
more.
are literally 2 separate cases. So you can imagine that the cost would be more for those.
Yeah, it's a range.
So it's a range. But I think outside of Beverly Hills pricing, you're looking at a range of anywhere from $12,000 to $25,000. I think is probably more
For a straight abdominoplasty.
for an abdominoplasty,
Yeah.
depending on how much liposuction you're going to do.
Yeah, if you're in, Kansas City, Missouri, it's probably, $15,000 or something like that. It's very dependent on the local economy and what these things cost to, everything in Beverly Hills is,
It's way more expensive.
it's just bananas. The state has lost its mind.
True.
But, there's also some people in Beverly Hills who really know what they're doing, and, that's where we are, and we do a lot of these, and they turn out really nice.
They do. They really do. I would say this is up there with my breast reductions in terms of high patient satisfaction, life-changing, I've been told. So this is a good one. This is a really
that's
satisfying.
mostly what you do, are these big body cases for, moms who've, and also the massive weight loss.
The massive weight
your
loss
massive
patient?
weight loss patients,
Yeah.
like the stuff that you showed in Paris. I mean, you had the entire panel like going like, oh my God, I would never do that case. Like it was amazing.
It's life-changing. But even just for like the mom I had who was a skinny mini Pilates instructor and her abdominal wall muscles didn't work. Like you can't be a Pilates instructor. She's like, I literally had to tell my clients what to do because I can't show them. Her core was just so separated.
It was wrecked.
She had like no fat, barely any skin, but she needed the muscles addressed. So all of these patients, huge levels of satisfaction. So that's pretty much it for our 101. I hope we got everything compact into the pre, during, and post expectations.
That's great.
For more information, feel free to check out the remainder of our Tummy Tuck deep dives. But for now, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.